All right, everybody. I think we'll go get started. Good morning, everybody. Thanks, Amir and Peter, for having me here today. But most of all, thank all of you guys for rolling in here first thing in the morning after maybe a late night here in Las Vegas. Let's kick things off today by talking about state-of-the-art stroke care. But what is state-of-the-art? So I would argue this depends a great deal on where you practice. So I'm lucky. I work mostly at a big tertiary center. We're a comprehensive stroke center. But I also spend some time working at a small critical access emergency department. And I can tell you that the state-of-the-art care of stroke is very different at those two institutions. So at the Comprehensive Stroke Center where I work, we've got all the bells and whistles. So of course we give thrombolytics, we've got 24-hour neurology coverage. I can have a neurologist or a neurology resident at the bedside of a patient presenting with an acute stroke within minutes. I can get an MRI 24 hours a day. I can get a CT angiogram or a CT perfusion scan, whatever I want. Interventional radiology is available around the clock, and we send a good number of our patients upstairs for mechanical thrombectomy. But where I work, we also have this thing, right? So we have a stroke ambulance. Now, this is just part of a research study. It's a pilot project. I'm not particularly involved in it. I don't know if this is going to end up being a permanent thing or not. It's only available during banker's hours, but during those hours, if somebody in the city of Indianapolis has a stroke, this ambulance is dispatched to the scene, to their home, to their workplace, wherever they've had their symptoms occur, and there's an attending neurologist on board. And see how big this ambulance is? Maybe it's a little hard to appreciate from this picture, but it's a really big ambulance. It has a CT in it. So if a patient has a stroke and this thing is dispatched, they can have a CT done, assessment by a neurologist, TPA initiated before they even make it to the hospital. So that is state of the art. But most of us don't work in that environment, do we? Does anybody else here have anything like the stroke ambulance, that thing? Yeah. So I see one or two hands here, so a couple people. Who works in a comprehensive stroke center? So around the clock, neurointerventional radiology, around the clock neurology, all that kind of stuff. So a couple more hands. Most of us don't work in those places. So for most of us, state-of-the-art stroke care in 2019 means giving thrombolytics when appropriate and indicated, and considering referral to a comprehensive center for patients that might be eligible for neurointerventional mechanical thrombectomy. So in that context, when we talk about state-of-the-art care in 2019, I want to really cover two things today. The first one is not so much of a revolution in stroke care, but is more of an evolution, something that's quietly changed over the last several years, and that is that the indications for TPA have expanded. A better way to say that is the exclusions that prevent people from getting TPA have actually loosened up quite a bit based on new data that has been studied since the original studies looking at TPA. The second thing we're going to talk about is truly a revolution. We are in the era of mechanical thrombectomy for patients with strokes due to large vessel occlusions. That is a rapidly changing area, even over the course of the last year or so. I want to bring you up to speed on that a little bit. Here's what we're not going to do today. I am not rehashing the debate, right? We've all heard the debate about are thrombolytics good or are thrombolytics bad a million times. And hopefully everybody's heard that debate enough that they've made up their own mind. I will share my own bias with you so you know. First of all, I have no conflicts of interest whatsoever. I don't take a penny from a drug maker, a device maker, or anybody. Anything I'm telling you today is my opinion based on my view of the literature. But my bias is that thrombolytics on balance are a good thing. I think that's controversial, of course, in the emergency medicine world. But my read on the literature is that on balance, our patients benefit from thrombolytics when they get them. Yes, there's harm, but on balance, the good outweighs the harm. So that's where I'm coming from. And I think most of us would agree, whether we believe in them or not, they have become standard care for patients with strokes. If you want to have a discussion with your patient about why you think they're bad and engage in some shared decision-making, totally fine. But we're going to start from the premise that thrombolytics are pretty standard care of what we do. The other thing I'm not going to do today is make this an EBM lesson. The literature here is vast. We could probably spend the next 40 minutes dissecting any one of these studies. We're not going to do that. Let's try to get a pragmatic understanding of the current literature, guidelines, and practice. So let's talk about thrombolytics. And boy, do we talk about thrombolytics, don't we? You go to any stroke lecture, just like this one today, and there is a lot of conversation about thrombolytics. You would think that is the only thing that we do for stroke patients, is give them thrombolytics. But the fact of the matter is, we don't often do it. Think about the last 10 stroke patients you saw. How many times did you give thrombolytics? Statistically, maybe 0 or 1. Only about 3 to 6% of people who present with an acute stroke will be treated with TPA. It's a pretty small number, isn't it? There are lots of reasons for that number. Far and away, the most common reason people don't get TPA is they're not eligible for it. And the most common reason they're not eligible for it is because they present too late to get TPA. They present after 4.5 hours, so they're not eligible to get it. There are probably other things that explain this too. Some physician reluctance, I think, is part of this picture. I will tell you that this number is creeping up over time for a couple of reasons. One is I think there is less physician reluctance, and the other, as I mentioned, the exclusion criteria are loosening up for these patients a little bit. I'm going to talk about a number of different papers and guidelines and studies today. If you want to read one that's really great, this is one to go get and look at. This was a position statement published by the American Heart Association, American Stroke Association in the journal Stroke in 2016, where they really laid out the scientific rationale for the different exclusions that exist and made some solid recommendations about who you can give thrombolytics to and who you cannot give thrombolytics to or who you shouldn't. So there are some surprising things in these most current recommendations, or things that I think some of you are going to find surprising. Reasons we used to not give thrombolytics, but we have learned that it is probably beneficial for these patients. Because the old exclusion criteria for not giving thrombolytics, they're all based on those original studies, ECAS, NIHSS, and those exclusion criteria were pretty tight. Mild symptoms, all right? So this is one where we typically would not give thrombolytics to patients if they had a mild stroke defined by an NIH scale score of less than 5, or some people would say less than 6. The thought here always was, listen, I'm giving them this medicine that could cause harm. It could cause them to bleed into their brain. I'm willing to accept that risk if I can make a big difference in this person's life. But if they have really minor symptoms, the upside there is not potentially as great, so why would I take the risk and give that to these patients? There were very few studies, or there were very few patients with minor strokes in the initial studies looking at thrombolysis, but doing some post hoc analysis on them and some additional studies that have been done looking at patients with minor strokes have caused the American Stroke Association to update their recommendation. They say for patients with mild but disabling stroke symptoms, IV TPA is indicated within 3 hours of symptom onset. So it is okay to give thrombolytics. It is probably a good thing to give thrombolytics to these patients who have minor strokes. The other thing to remember is the more minor the stroke, the less likely that patient is to bleed. So intracranial hemorrhage for these patients, this group of patients, is less than 2%, so less than we see across all stroke patients. Let's back up for a second and talk about that NIH stroke scale. So maybe you're using this in your clinical practice, or maybe you're not. I would argue that you should if you're not. So the NIH stroke scale is an 11-item physical examination. They get points for findings on each of these 11 items that you go through. And the scores that they can get range from 0, which is just a normal person, to 42, which is essentially completely comatose. The NIH scale was developed as a research tool when they were first studying things like thrombolytics, but it has evolved to become a useful clinical score. I resisted this for a long time. I'm like, I could do a neuro exam. I can talk to the neurologist about my neuro exam. I don't need to sit there and calculate a score. But as I've adopted this into my practice, I've really learned to like it. It does a lot of things for you. One, it predicts outcomes. The more severe the stroke, the worse the outcome is. Not a big surprise there. Two is it allows you to follow your patient over time in an objective, quantitative way. You can walk back to the bedside and say, oh, I think they're a little bit better, or I think they're a little bit worse, but you can recalculate an NIH score and see they've gone from an NIH of 8 and now they're worse. They're an NIH of 15. Quantifies that a little bit for you. But the big reason I think it's important to learn to do this is because it is the language that neurologists speak. And as emergency physicians, that's what we need to do. We need to be able to speak the language of our consultants. When I talk to an ophthalmologist, I need to be able to explain the eye exam to them that I'm seeing in their language. Same with neurologists. These calls to the neurologist are much easier when you can tell them a little bit of the story and then say, their stroke scale is 14. They know exactly what that means, and it helps them make decisions. Like I said, it's hard to remember to do this. I always have to cheat a little bit. There are lots of different apps you can find on your phone, medical calculators. They almost all have the NIH stroke scale. It's pretty easy at the bedside. It only takes a few minutes, and the more you do it, the quicker it gets to flip through this and do it. So by the NIH stroke scale, the definitions vary a little bit here. A mild stroke is considered to be a score less than 5 or 6, and anything over 25 is considered to be a very severe stroke. So what's a mild stroke? We're saying you can give thrombolytics for mild stroke. Does that make sense? Not all strokes are created equally, and not all minor strokes are created equally. Remember, the guideline said you can give thrombolytics to a minor stroke if it is judged to be a disabling stroke. So that's a little bit of subjectivity there on the part of the patient and the clinician. So there needs to be a discussion. So this is an example. So this is a person with a mild stroke, and they had mild dysarthria, which got them 2 points, partial facial droop, and a mild right upper extremity drift. So they drift a little bit but didn't hit the bed. I think about this in the context of me. What if this person were me, and I'm having trouble speaking, and I've got some weakness and clumsiness in my right arm? That's disabling. That's a life changer. That means I probably am not going to be able to do my job. So if I have a very low risk of hemorrhage for getting thrombolytics, even though my stroke is mild, I would personally want to do what the guideline suggests, and that is get thrombolytics. What about old age? So this was another one that when thrombolytics were first adopted, say 20 years ago or so, it was thought that we should not be giving these to very old people. We shouldn't be giving them to people over 80. The reason for that, it's true, the risk of hemorrhage is higher in patients who are elderly than it is in younger patients. So again, we've got more of a downside there. Is that still balanced by a good upside? And that's true. Older people do hemorrhage more. But again, as this group has been looked at more and more, the benefit, even though they have a higher risk of hemorrhage, the overall benefit remains even in elderly people. So current recommendations by the American Stroke Association are IV TPA within 3 hours, equally recommended for people less than 80 and more than 80. No difference there. A lot of people find that surprising. Notice, though, it says within 3 hours. This is going to come up again in a minute. So it's a little confusing sometimes. What's the cutoff for stroke, right? When I was practicing 15, 20 years ago, it was 3 hours, right? That was the rule. If you were not there after your stroke and couldn't get TPA within 3 hours, that's a hard stop. No one beyond 3 hours. And then like 10 years ago, there was this other data that said, well, maybe it's 4.5 hours. So which is it? Is it 3 or is it 4.5? It's kind of both, all right? So most patients are eligible for TPA up to 4.5 hours. But in that window between 3 and 4.5 hours, the exclusion criteria are tighter, right? And this is a good example of that. If it's less than 3 hours or over 80, you can give thrombolytics. If it's above 3 hours, if it's between 3 and 4.5, it's less clear what the right answer is. So that's probably a patient individual judgment based on a shared decision-making discussion or talking with your neurologist or whatever. So the exclusion criteria are tighter as you move up to 4.5 hours. What about patients with rapidly improving symptoms? We've all seen this. Have a patient wheeled in there by the ambulance. When they first get there, they're completely aphasic and they're not moving their right side at all. It's completely a flaccid hemiparesis. Send them off to the CT scan. They come back to the room. You go back to the bedside to see them. They're nowhere near normal yet, but they're a little better. They're starting to talk a little bit. Still can't understand what they're saying, but they're starting to talk. They don't have much strength on their side, but they're starting to move that right side. Do I give TPA to this person? Tough question, right? I don't want to give TPA to a person who's having a TIA and expose them to the risk of hemorrhage. If they were going to get all better on their own, what do you do? Do you wait or do you not wait? American Stroke Association says you don't wait. If they have improved but continue to have disabling symptoms, you go ahead and treat them. Most of those patients aren't going to go all the way to normal. If they're going to improve all the way to normal, they're going to do so rapidly. There's this process that occurs of partial recanalization. Sometimes that re-clots off again and they get worse again. So unless they've gotten back to normal or gone back to essentially no symptoms, if at the time you're getting ready to make that decision they're still disabled, go ahead and give it. Practically speaking, I think that by the time the patient has gotten their scan, you're getting ready to give the TPA. If they've not gotten back to normal in that period of time, if they're still significantly disabled, go ahead and give the TPA. American Stroke Association would agree with that. So patients who are older, patients who have rapidly improving symptoms, patients with minor strokes, all still get TPA. And it's a little bit different than what we maybe did 10 years ago. Something else is different than we had 10 years ago, and that is we've got some new drugs that our patients are on, right? So what do we do with the patient who's on a NOAC or DOAC or whatever you like to call it? These direct thrombin inhibitors and 10A inhibitors, drugs like apixaban, rivaroxaban, and dabigatran. When NIHSS study was done in the 90s, when ECAS was done, these drugs didn't exist. So we don't have much data at all on what to do when a patient's on these drugs. Let's back up for a second. What do we do with warfarin? So warfarin is a little bit tricky. It's not a hard contraindication. It is a little bit controversial. In some of the European Society guidelines, warfarin's a hard stop. If the patient's taking warfarin, they don't get TPA. The exclusion criteria from the American Heart Association, American Stroke Association, as you probably know, is a little more liberal. And if the patient is presenting within 3 hours and they're on warfarin, as long as their INR is below 1.7, if they're subtherapeutic, you can go ahead and give the TPA in that patient. This is another example of the difference between the 0 to 3 group and the 3 to 4.5 hour group. In the 3 to 4.5 hour group, the recommendation is still TPA is contraindicated in those patients. So a little bit of difference between the groups. So early on, you can give warfarin. So that's warfarin. What about NOACs? We just don't know. But it sounds like a really bad idea, right? There is good reason to think that these patients would not do well. It's not been studied, but the recommendation, I think, is the right one. Just don't give it. If they're on apixaban, rivaroxaban, or dabigatran, no, don't give it. Now, there are a couple of exceptions to that. They talk about you can give it if all these crazy blood tests are normal. So PTT, platelet count, eccrine clotting time, thrombin time, direct factor 10A, activity assay. I mean, I don't know where you work, but I can't get all this stuff done to tell me to do TPA or not, right? That's not very helpful. The other exception is, though, assuming normal renal function, right? So the patient's metabolizing this normally. Assuming normal renal function, if the patient hasn't had a dose in more than 48 hours, you can give it. You better be sure about this, right? But we can picture this scenario. The patient with AFib that ran out of their apixaban 2 weeks ago hasn't seen their doctor to get it refilled. Well, what happened? Boom, they had a stroke. Yes, if it's been more than 48 hours since their last dose, you can go give TPA. Otherwise, if they're on these medicines, it's a no-go for TPA. So those are some of the changes that have occurred with thrombolytic exclusion criteria and exclusion criteria. Let's talk about the other thing now, mechanical thrombectomy. And I know from the raise of hands earlier, not many of you work in places where they do this. You work in places where it's actually much harder. You don't have the people there in your hospital, and you've got to figure out, do I send this patient to go get a mechanical thrombectomy or not? So big decisions that have to be made. So let's walk through this a little bit because it's rapidly evolving and it's a little bit complex. Let's try to boil it down. So the idea of mechanical thrombectomy is appealing to each and every one of us, isn't it? We know that TPA doesn't work particularly well for large vessel occlusion strokes. And what do I mean when I say large vessel occlusion? Internal carotid, yes. First segment of the MCA, the M1 segment, yes. Other vessels, kind of depends on what study you look at. M2 segment, M3 segment, basilar artery, anterior cerebral artery, they may fall into this category. But we love the idea, right? Go in and suck out the clot. That's what we do for heart attacks. Those patients do great. We should do the same thing for a brain attack. So does it work? Well, it's been around for maybe a decade or so. There were a whole flurry of studies around 2013 that looked at this. And they said, guess what? Doesn't work. Doesn't help people. These patients are not doing any better when they go for mechanical thrombectomy. So what changed? Why are we doing this now in 2019 if these studies in 2013, these big studies, said they didn't work? Well, there were some problems with these studies, and things have changed. We have gotten much better at selecting our patients, and we've also, technology has advanced, and there are some newer, better devices. So let's talk about patient selection first. Mechanical thrombectomy is only going to work if you have a clot in a big vessel that you can suck out. If you've got a bunch of little clots in a bunch of tiny little vessels, mechanical thrombectomy is not going to work. So mechanical thrombectomy is only for patients with large vessel occlusions. How do you decide if a patient has a large vessel occlusion? Seems like the answer would be pretty straightforward, right? You take a picture of it. You do a CTA. That's what we do now. In these studies in 2013 that didn't show a benefit, that's not what they did. They used clinical scoring systems. And basically they said, you've got a really bad stroke. Bad strokes are more likely to be due to obstructions in big vessels. So if your stroke was bad, and they define that differently, there are all kinds of different scoring systems and everything that they use. They said, if you've got a bad stroke, we're going to enroll you in this study, we're going to take you up to the IR suite, and we're going to do a thrombectomy on you. The problem was, in large numbers of patients that had bad strokes that you would think would be due to a large vessel occlusion, they get them to the cath lab, they put in the sheath, they go up and squirt the dye, and they find there is no occlusion, right? There's no obstruction of that vessel that was actually there. How is that patient possibly going to get better if the mechanical thrombectomy can't even be done? So no occlusion, no obstruction was definitely part of the problem. Technology has advanced as well. The old first-generation device was the Mercy device. This was actually developed for other purposes, and it was kind of a corkscrew thing that went into the clot and sucked it up. So the more current devices are stent retrievers. This has become the standard. So the concept with this is that you go up here and you put this little sheath, this micro sheath through the clot. Then you retract the micro sheath. I mean, I say you, it's not like we're doing this, but our interventional radiology colleagues are doing this. Retract the sheath that allows the stent to deploy into the clot, and then they retract that whole thing back. Right? That's how they remove the clot with these stent retrievers, and they seem to work quite a bit better. So doing this, using patients only that had a CTA or MRA proven large vessel occlusion, and using stent retrievers. A number of studies were done in 2015. We're not going to go through each and every one of these. You've probably heard of some of these, like Swift Prime, Mr. Clean, Escape, Revascat, all well-known kind of big studies. And these studies said, hey, you got to have a proven LVO. Now, these studies, one of the hard things that makes it terrible, you wish everybody get together when they do these studies and kind of agree on what they're going to do. They all did things a little bit differently. They used different cutoff times. One study said, hey, we're only going up to 4.5 hours. Another study said, we're going up to 12. Some of the studies said, we're only going after the internal carotid and M1. Some of the other studies said, no, we're going after even more. We're going after M2 clots. We're going after basilar artery clots. And then the other tricky thing is, some of the studies included patients who were treated with TPA. Some of the studies did not also treat the patients with TPA. So a little bit of issues there. But there's a really nice meta-analysis that put all the data together from these studies that were done in 2015. It was published in Lancet in 2016. And these are the outcomes. This is amazing stuff for patients with big strokes, large vessel occlusions, who had a modified Rankin score of 0 to 1. So you remember the modified Rankin score, it's a 0 to 6 scale. 0 is normal. 1 is you got a little disability but can do all your activities of daily living. 2 is you got some maybe more disability, you can live on your own but need some help, all the way up to 6, which is dead, right? So 0 to 1, or some people say 0 to 2, are considered good outcomes. This is like patient-oriented stuff. In the mechanical thrombectomy group, 27% had a good outcome. In the control group, 13%. Number needed to treat is 7 for a good outcome of patients that got mechanical thrombectomy. Big, big news. So, the American Heart Association, American Stroke Association now has a level 1A recommendation that mechanical thrombectomy should be done. Here are their criteria. Occlusion of the internal carotid or M1 segment, have to have an NIHSS score less than 6. So this is not for your little minor Ditzel strokes. This is for more severe strokes. And if treatment can be initiated within 6 hours of symptom onset. That's the standard. If you can accomplish that at your institution or by transferring someone, if they've got a large vessel occlusion, they're having a significant stroke, and you can get there within 6 hours, that patient should be treated with mechanical thrombectomy. Now, an important question is, do I give TPA as well? Is this TPA plus thrombectomy or just thrombectomy? Unanswered question, right? There's a lot of debate about that. There's ongoing research looking at this, but that question remains unanswered. Great. What do you do tomorrow when you're on your shift? Here's the deal. If you're working at a stroke center, comprehensive stroke center with neurointerventional radiology, you've got a protocol for this. Everybody's gotten together and decided you do or you don't. We don't. Some places do give the thrombolytics. If you're at a non-stroke center and are contemplating sending that patient for mechanical thrombectomy, if they meet the criteria for thrombolytics, give them thrombolytics. They can still do the mechanical thrombectomy. The issue would be, what if they can't? They get there, they don't actually meet the criteria, there's some, logistical reason, whatever it is, then you would have missed your opportunity to give that patient thrombolytics. So still give them thrombolytics if they meet the criteria, and then send them for mechanical thrombectomy. All right, so those are patients who've had stroke within 6 hours. What about the patients who've had symptoms longer? Does mechanical thrombectomy still work for those? And this is an important thing. This is something that's always been frustrating to us as clinicians, isn't it? Someone rolls in with symptoms for 8 hours, or even worse, someone went to bed at 10 o'clock last night feeling fine, got up at 6 a.m. with stroke symptoms, and is in your emergency department at 7 a.m. Did that stroke occur at 5:45 in the morning, or did it occur at 11 o'clock last night? You don't know. You have to assume it happened right after they went to bed, and you're left with saying, gosh, you're having an acute stroke, but, here's an aspirin, and we're going to admit you to the floor and hope you don't aspirate, right? I mean, that's kind of it. Have physical therapy see you. Not a lot we could do for those patients. That has all changed as of last year for a small number of these patients, just the patients who have large vessel occlusions. There were 2 studies done. Dawn and DEFUSE are the studies, and they were both published, New England Journal, 2018, and are already incorporated into the latest AHA, ASA guidelines. So here's the thing with these studies. This is where it gets a little different. This is different than the 0 to 6 hour population. These are patients after 6 hours, up to 16 hours in one of the studies, 24 hours in the other study. These are patients with large vessel occlusions, so they have big strokes. NIH score of 16 or 17 in the 2 studies. They have to have a radiographically proven large vessel occlusion. And then this is where it gets a little trickier. They have to have evidence of an ischemic penumbra that's salvageable. Now, with the 0 to 6 hour patients that we just talked about a moment ago, the thought is that's a fresh stroke. That's a new stroke. Almost by definition, they haven't been having their stroke for that long. They're still going to have some penumbra. And that's why those patients benefit. They don't need further testing to figure out if they've got a salvageable penumbra. But if your stroke was 15 hours ago, maybe you have salvageable penumbra, or maybe the stroke's completed. Maybe the brain tissue's all dead and infarcted, and it's too late. Doesn't matter if you take that clot out. So to be enrolled in these studies, the patients had to have evidence of salvageable ischemic penumbra on CT perfusion study. You could also do MRI diffusion perfusion study as well, but most of the patients had CT perfusion study, and that's what I think most of us, if we have this, would have at our institution. Let me talk about CT perfusion testing for just a minute, because it's not as confusing as it sounds. So if you've ever seen the pictures, they look like this. You're like, whoa, what are they injecting those patients with that they have all these red and green and yellow and blue pictures of the brain, you know? It's just an IV contrast study, just an IV contrast study of the brain. But here's what they do. They take multiple sequential images over a period of about a minute. So the patient's laying in the scanner. They get a non-contrast head. They squirt the contrast in. They kind of do it kind of a slow push. It's very specifically timed. It's very rigorously protocolized. But they give them the contrast over time. They take a picture. Then a couple seconds later, another picture. Some of the protocols just have them continuously getting kind of a cine picture. But they get multiple sequential images over time. And that allows them to look at each little gram of brain parenchyma and say, how much contrast is attenuating that brain parenchyma at time 0, at time 1 second, at time 2 seconds, and so forth. It's a high radiation study, by the way. These people are getting essentially multiple CTs of their head all in a row. So that allows them to follow that contrast over time. So for each area in the brain, they can do some calculations based on that. They can determine cerebral blood flow to any little area of brain tissue. They can determine cerebral blood volume, and they can determine transit time, how long it took that contrast to get to that part of the brain. So normal brain, goes without saying, but has normal cerebral blood flow, normal cerebral blood volume, and a normal transit time for that contrast to get there. Infarcted tissue, dead tissue, completed stroke tissue will have essentially 0 blood flow, 0 blood volume, and an incalculable transfer time. What about the ischemic penumbra? So ischemic penumbra will have actually a near normal blood flow and a near normal blood volume, but the transit time will be slower. The idea being that that blood had to get there through a more tenuous collateral circulation. So it takes longer for that tissue to light up. So that is conceptually how they differentiate normal brain, dead brain, ischemic penumbra. And then there are all kinds of calculations that they do to figure out the volume of penumbra, the ratio of penumbra to dead tissue. Not going to get into all that here, but that's the general concept. They used to, when they first started doing this, the radiologists just kind of look at it and be like, it looks like there's some pretty good penumbra there. Now it is all this proprietary, very advanced software that does all these calculations and spits out some numbers. So you're not necessarily going to be looking at this and making decisions, but I want everybody to understand conceptually what's being done when we talk about CT perfusion studies. So that's your CT perfusion study. So how did these patients do? Stroke more than 6 hours, large vessel occlusion, evidence of ischemic penumbra. They went to the IR suite and had a mechanical thrombectomy, and these are the results. They used a little looser criteria for good outcome, a modified Rankin score of 0 to 2, and in the patients that went to thrombectomy, nearly half of them had that good outcome, compared to 13 to 17% that didn't, giving you a number needed to treat of about 3. Folks, that's a game changer. That has taken a group of patients that we could previously do nothing for, and now we can do this thing that makes them quite a bit better. So that is a wonderful thing, yes, and is going to have a huge impact. By the way, Not so huge of an impact because of how many patients it's going to help, because the people that meet all those criteria is actually a fairly small number of people. For everyone in this room, it's going to have a huge impact on all of us because we can no longer say, here's your aspirin, going to admit you to the hospitalist, I hope you get better. We actually have to go through this process of figuring out, is our patient one of this small number of patients who's eligible for this pretty good therapy? So, what do we do with all this information? Well, the question really starts before the patient even gets to us. Where does EMS take them? So if you've got a patient with a stroke and 5 miles up the road is a hospital that could give that patient TPA, but that's about it. But 30 miles away, you've got a comprehensive stroke center that could take them to mechanical thrombectomy. What does EMS do, right? This is evolving, and it's going to vary a lot from locale to locale. And hopefully every EMS system has worked this out with a protocol. But the current recommendations, I think, are the right ones. And that is, you got a patient with a stroke, you take them to the closest place that can give them TPA. They can figure out from there if the patient needs to be transferred somewhere else. And I think that's the right answer. But there are all kinds of different scenarios you can think about, right? What if you're in a big city and you have hospital A that's a mile away that can only do TPA? There's a comprehensive stroke center, but it's only another 3 minutes down the road, right? Well, maybe you do take that patient there. Maybe you try to stratify how bad the stroke is. Lots of different ways to do this, something that should be worked out by EMS in each kind of locality. But the overall recommendation is don't take them 20 miles down the road to get to another hospital. Take them to the closest place that can get them TPA quickly. So what do? You're working in a non-stroke center, and this patient hits your door. All right, you're going to get your non-contrast head CT, and the quality measure for that is that on average, those should be done 20 minutes after the patient gets there. And you're going to give that patient TPA if TPA is indicated. Nothing about mechanical thrombectomy has changed any of that. That is the same. You still do those things. So this has not changed. What has changed is that you now have a second question you have to ask, and that is, does the patient have a large vessel occlusion that might benefit from mechanical thrombectomy? And you not only have to ask the question about patients with hyperacute strokes, you now have to ask that question about patients who had wake-up strokes. You have to ask that about questions who had strokes that started 10, 12, 16, maybe even 24 hours ago. So you now have a new question to ask. How are you going to answer that question? The most direct answer is to get a CT angiogram, and most people work in places where this can be done. Do you need to get a CT angiogram on everybody? I would argue, I think you should. You don't technically have to, though. Some places will have protocols in place where you can try to stratify using a scoring system to say, this patient had a bad stroke, we should get it, this patient didn't. So NIHSS stroke scale of 6 or greater is a thing that is a cutoff that some places will use, and that's fair. There are other scales. There's the JUST scale from Japan. There's a Cincinnati scale that's different than the pre-hospital stroke score we're all familiar with. None of these have really been demonstrated in the literature to be perfect at all. So I would argue that any kind of significant stroke with disability probably should have a CTA. But there are other options in terms of using scoring systems and so forth that you may use at your institution. When do you get the CTA if you're getting it? Do you get it right away at the same time you get the head CT? Or do you get the non-con, then give the TPA, then send them back? I would argue you probably just get it right up front if you can. That's what we do in our institution. Everybody presenting with a stroke, it's a stroke alert, gets a CT and a CTA right up front. Now, again, standard of care depends on where you practice. If you work somewhere where the radiologist won't let a patient look at a bottle of IV contrast without having a GFR calculated, and it takes you 45 minutes to get those labs back, don't wait. Get the non-contrast head CT, get the CTA later. But you need to get it for most of these patients to figure out if they have a large vessel occlusion. I would advocate getting it early if you can. If they have a large vessel occlusion, the next question is, when did their stroke start? If it's less than 6 hours ago and they have a large vessel occlusion, that's a candidate for mechanical thrombectomy. Get on the phone with your referral center. That patient probably needs to be transferred. If they have a large vessel occlusion and the stroke was 6 to 24 hours old, maybe they're a candidate. It depends if they have salvageable ischemic penumbra. So that patient needs a perfusion study. If you can do that at your institution and then talk to the receiving hospital, that's fine. Working in a hospital where we receive a lot of these patients, I see most places doing the CTA, identifying the large vessel occlusion, identifying the patient as a possible candidate for neurointerventional radiology, and then sending them to us where we can get the perfusion scan and sort that out, right, if they really are candidates or not. But that's the next thing that they need to determine whether or not they might be candidates for reperfusion study. I think this all gets a little confusing, and it's a lot to think about, but hopefully I've kind of sorted that out a little bit. I think a critical thing to mention is that these are not decisions you make on your next shift, right? This needs to be protocolized in your institution. So if you're an emergency physician working in a hospital, get yourself on the stroke committee so you can sit down with the hospitalists, the radiologists, and the neurologists and work this out in advance. So when that patient shows up at your door, you know exactly what you're going to do. And hopefully you have a little bit better sense of what needs to be done after our talk today. Guys, I got a few minutes left. I can take some questions, but thanks very much for your attention. It's fun to talk about. Thanks. Yes?
CTAs are pretty standard, so typically comprehensive stroke center is going to be okay with whatever community hospital CTA protocol they get.
I've never, I guess I maybe shouldn't say never, but yes, they're pretty standard. Our neurointerventional radiologists and our neurologists are generally happy with the CTAs that are done at outlying institutions. Because the problem is, I think they appreciate them being done in a way. Otherwise, so many patients get referred in that ultimately don't have a large vessel occlusion. Our consultants will happily take those patients. If you're at a smaller hospital and you've got a big stroke and you feel it needs to be somewhere else, send it. I think that's the way most comprehensive stroke centers look at this. But yeah, it is nice to know, because what that allows people to do if they've had that CTA done and they've looked at it through teleradiology is they're like, yeah, we got to get the IR suite opened up, call some people in, get this thing ready to go. So yeah, I've not seen a problem with, they're pretty standard. As long as your institution can do them, they're probably going to be good enough. Perfusion study is going to be a little bit different issue.
And no new data on wake-up strokes and TPA?
Yes. Unfortunately, we didn't have time to get to that. So it's not ready for prime time yet, but this is going to be the change. This stuff we're talking about with these perfusion studies for mechanical thrombectomy, the same thing is coming down the pike for thrombolytics, where they're doing some perfusion studies and saying, you know what, there's penumbra, these patients may be eligible for that. There have been at least 3 studies published looking at that. They are promising for using perfusion studies to guide TPA. So at some point, these hour cutoffs may go completely away. It may be all based on advanced imaging, but we're not there yet. So yeah, that's not going to affect anybody's practice today. No one is doing that outside of research protocols right now. So yes, at some point TPA might be guided by perfusion study. It's being looked at, but it's not in the guidelines or ready for standard practice yet. Yes? So 2 questions. One question was, how long does it take to do the perfusion study? Second question is CTA versus MRA. Perfusion study is done very quickly. So they're in the CT machine for a minute or 2. And the computer, it probably varies from institution to institution. I can only speak to my personal experience. We get results back on those quickly. I mean, it's within, 15 minutes, 20 minutes. It's going to depend on the radiologist and lots of other things. But it's not a super time-consuming study, which kind of dovetails nicely into your next question, CT versus MRI, or CTA versus MRA, or CT perfusion versus MR perfusion. They both seem to work equally well. They're both good studies. There's not a whole lot of difference between the two. CTA is CT perfusion seems to be the standard at more institutions, and as we all know this from every other study we order, right? It's a matter of they can get done more quickly and they're more available, right? Most hospitals always have a CT tech there. They don't always have an MRI that's available, and it just takes a lot longer to do that study, which doesn't make as much sense to me when you're talking about a really time-sensitive thing. So our standard is use CTA, CTP, but the MRA and MRP work just as well, just they take a little more time. Okay, one more, yeah. So, yes, question was, what about antiplatelet agents? Antiplatelet agents are okay. So the AHA, ASA recommendations are if they're on aspirin, if they're on Plavix or clopidogrel, or even if they're on both, that is not a contraindication for TPA. Thrombocytopenia is platelet count less than 100,000. But if that lab is delayed for you for whatever reason, American Heart Association says you don't have to wait for the lab if you have no other clinical reason to suspect the person is thrombocytopenic. So platelets aren't as big of an issue except for that cutoff. Yes? So the question is, you give the TPA, you're going to get this CTA, how long do you watch them? How long do you wait before you transfer them? I would get it essentially immediately. And once you get that back, and if it shows a large vessel occlusion, the decision is considered to be made at that point that they can go and get mechanical thrombectomy. The American Heart Association says, based on the data that they've looked at, that you should not give TPA and wait and see if they get better, for example, and then decide. Like TPA, decide if it's a large vessel occlusion. If it is, send them for thrombectomy. Don't have to wait around and see if they're going to improve and so forth. I'm going to stick around. I'll be around after the break. I don't want to cut into Amir's time here. So thank you very much again, guys. I appreciate it.